What if the future of complex reconstructive surgery doesn't rely on synthetic grafts or, massive tissue flaps, but rather on the regenerative stem cells hiding in the very fat we discard every single
It's
day?
a fascinating concept.
It really is. Welcome to this targeted revision deep dive. If you are a resident preparing for the FRCS Plastic Surgery Board exams, you are in exactly the right place today.
Absolutely.
And we are skipping the usual banter because your time is valuable. This is a high-yield, purely question and explanation session focused entirely on modern liposuction and fat grafting techniques.
Right, we're looking at the foundational anatomy, the clinical assessments, the underlying mechanisms of operative techniques, and the critical complications you absolutely must know for your exams.
But before we make a single incision into this material, you need to head over to medsynclimited.com.
Yes, do that right now.
Get the FRCS Plastic Surgery Anki Beck. It contains over 6,000 questions arranged by topic to aid your recall of these exact facts.
And it's directly based on the keynotes in plastic surgery.
Exactly. It is an indispensable tool for your active recall.
And while you are listening, make sure to hit follow on your app so you catch all our future revision deep dives.
Yeah, and please rate the show if you find this session valuable for your preparation.
It really helps.
So let's get straight to the operating table. Before we can safely remove or repurpose fat, we have to understand the precise architectural layers we're navigating.
Because it's definitely not just one homogeneous yellow mass.
Right. Think of the subcutaneous tissue like the levels of a house. When you have a cannula in your hand, which floor are you safely renovating? And which one holds the structural plumbing that you absolutely cannot touch?
That's a great analogy.
Break down the 3 distinct layers of subcutaneous fat for us.
Well, the top floor, or the roof, is the apical layer.
Right.
So this sits immediately deep to the reticular dermis.
Structural plumbing zone.
Exactly. The fat in this layer surrounds the sweat glands, the hair follicles, and most importantly, the delicate subdermal vascular plexus and lymphatics.
Which means this layer is strictly off limits for the cannula.
Completely off limits.
Because if you lose your depth control and aggressively suction that apical layer, you're stripping that vascular plexus.
Yeah, you are guaranteeing postoperative seromas, permanent erythema, pigment changes.
And ultimately, full-thickness skin necrosis.
A total disaster.
So what does it actually feel like if you are too superficial?
Tactile feedback is everything here. If you are in the apical layer, you will feel the cannula grating aggressively against the dermis.
You can actually feel that scraping.
Oh, yeah. And you'll likely see the skin tinting sharply. When that happens, you need to drop your hand and get deeper.
Right.
The next floor down is the mantle layer. Structurally, it consists of columnar fat cells that are tightly arranged within a vertical fibrous stroma.
And the mantle layer has some highly testable regional exceptions, right?
It does.
Because evolutionarily and functionally, there are areas of the body that require ultra-thin, highly mobile skin without that bulky padding of columnar fat.
Exactly. So for the exam, remember, you will not find a mantle layer in the eyelids, the nail beds, the dorsal nose, or the penis.
Knowing those exceptions is a classic multiple choice point.
It comes up all the time. Which brings us to the basement level, right? The deep layer.
Okay.
This is situated between the mantle layer and the deep fascia that directly overlies the muscle. Its thickness is highly variable based on the patient's sex, genetics, and diet.
And clinically, this deep layer is the primary target for liposuction, isn't it?
Yes. This loose areolar fat is where you are doing the bulk of your volume reduction.
But human anatomy isn't uniform. The architecture changes depending on the anatomical neighborhood. Let's look at the regional specifics, starting with the neck, the classic wattle deformity.
Right. In the neck, you are dealing with 2 distinct planes. Safely, fat is removed from the subcutaneous or supraplatysmal plane using liposuction.
Supraplatysmal is safe for the cannula.
Exactly. However, fat also lies deep to the platysma muscle. And for the boards, you must know that it is generally considered safer to remove this subplatysmal fat by direct surgical excision.
Usually via a submental incision, right?
Yes, rather than blind suction. This minimizes the risk of injury to the marginal mandibular nerve and, deep cervical structures.
Let's move to the abdomen, which is arguably the most common site you'll be tested on.
The subcutaneous fat of the anterior abdomen is divided. So superficially, you have Camper's fascia, which is present over the entire interior abdominal wall.
It's essentially fat contained within a loose, fibrous meshwork.
Right. But as you move inferior to the umbilicus, Scarpa's fascia defines an additional deeper layer known as subscarpus fat.
Got it. And as we move laterally to the hips and flanks, The anatomy really dictates the physical shape of the patient.
It does.
We have the superficial fascial system, or SFS, dividing the fat into superficial and deep layers. But the key mechanism here is the zones of adherence.
Yes, the zones of adherence are critical. These are areas where the SFS bypasses the fat entirely and tethers directly to the underlying muscle fascia.
And you must never transgress these zones with your cannula.
Never. Or you will create a permanent visible contour deformity. These tethers actually dictate the classic patterns of human fat deposition.
How so?
Well, in males, the primary zone of adherence runs along the iliac crest. This acts like a dam, confining the deep fat to the abdomen above it.
Which creates that classic android pattern.
Exactly. Whereas in females, that zone of adherence is situated more inferiorly. It localizes the fat over the iliac crest and the proximal thigh, creating the gynecoid pattern.
Are there other key zones of adherence to remember?
Yes, there are vital zones in the gluteal crease and the distal posterior thigh that maintain the contour of the buttocks.
And just to complete the regional map, there's a golden rule for the lower leg.
Right.
There is no deep fat layer below the knee.
Correct. Almost all the fat in the lower leg is located in the mantle layer, making liposuction there extremely technique sensitive.
Because you are operating almost entirely in that tightly packed, vertically oriented stroma.
It's very unforgiving.
I want to push back on a piece of classic dogma before we move on. Historically, we were taught that the absolute number of adipocytes in the human body is fixed after puberty.
Oh, the old balloon theory.
Yeah. The teaching was that weight gain or loss just inflates or deflates the cells you already have. But modern tissue analysis challenges that, doesn't it?
It completely refutes it. The old dogma is dead. Recent studies have proven that adult stem cells residing within the stromal vascular fraction of the fat can be recruited to differentiate into entirely new adipocytes.
Wow.
So the absolute number of cells can and does increase. Furthermore, the existing fatty tissue obviously still increases in overall size through adipocyte hypertrophy.
So it's both.
Yes, adipose tissue is a highly dynamic endocrine active organ. It is not just a static reservoir of triglycerides.
Which perfectly sets up the clinical reality. We know the tissue is dynamic. Now we have a patient sitting in our clinic. What are the specific clinical maneuvers and physical findings we must document to determine if this patient is actually a surgical candidate?
Well, beyond the standard anthropometrics like BMI, you must perform a dynamic physical exam. You perform a gentle pinch test across multiple zones to assess the exact distribution of the subcutaneous fat versus skin thickness.
And what about hernias?
Crucial. If you are considering abdominal liposuction, you must rigorously palpate for fascial defects.
Because detecting a microhernia hidden under 5 centimeters of subcutaneous fat before you pump the abdomen full of pressurized fluid is vital.
If you miss it, it leads to a catastrophic hollow viscous injury with your cannula.
And there is a massive clinical trap here regarding male patients and abdominal contours, isn't there?
The visceral fat trap.
Yeah.
In males, a protuberant abdomen is frequently driven by intra-abdominal visceral fat beneath the muscle layer, not just subcutaneous fat.
And intra-abdominal fat cannot be touched by a liposuction cannula.
Exactly. If you don't physically demonstrate this distinction to the patient preoperatively, showing them what is pinchable versus what is visceral, they will be highly disappointed when their abdomen is still protuberant postoperatively.
You also have to assess skin elasticity, right?
Definitely.
If the skin is already burdened with striae, severe laxity, or poor recoil, it simply will not retract after you remove the underlying volume.
You're essentially deflating a stretched balloon.
Which brings us to the cellulite rule. Patients will always ask if liposuction will cure their cellulite.
And the answer is an emphatic no.
Yeah.
You must specifically document the presence of cellulite, that peau d'orange appearance.
And we need to understand the mechanism of why liposuction actually makes it worse.
Right.
Cellulite is caused by rigid, shortened fibrous septa tethering the dermis down to the deep fascia. If you use a cannula to deflate the fat compartment around those rigid septa, you aren't fixing the tether.
No, you were just dropping the ceiling around it.
Exactly. You make the tethering look dramatically more pronounced.
It exacerbates the contour irregularity. And this highlights the absolute necessity of blunt preoperative counseling.
Because up to 20% of liposuction patients report some level of dissatisfaction.
Which is high. You have to prepare them for the turbulence of recovery. Dissatisfaction usually stems from asymmetry, visible ridges, cobblestoning, sagging skin, or troublesome port scars.
What is the exact timeline we need to brief them on? I mean, it's like a pilot briefing passengers before a flight. How long does the turbulence last?
Well, they need to expect drainage of serosanguinous fluid from the open incision sites for up to 36 hours.
36 hours of leaking.
Yes, this is normal but highly distressing to an unprepared patient. Then they will be bound in tight compression garments for up to 6 weeks to manage dead space and edema.
And the postoperative swelling.
That can take up to 6 full months to completely resolve and show the final contour.
All right, so the patient is fully assessed, consented, and marked while standing upright to map those topographic contour lines. Now we are in the operating theater. The evolution of fluid infiltration is a core exam topic. We started with the obsolete dry method, which caused massive blood loss. Then came wet liposuction in the early 80s. But the true paradigm shift was Jeffrey Klein's tumescent technique in 1985.
The tumescent technique changed the safety profile of the operation overnight. It utilizes a 3-to-1 ratio.
Meaning?
That means 3 milliliters of highly dilute infiltrate are injected for every 1 milliliter of fat you plan to remove.
But mechanically, how is injecting massive volumes of water stopping bleeding?
It's a combination of pharmacologic and physical mechanisms. You're creating a localized artificial compartment syndrome.
Ah.
The massive volume creates profound hydrostatic pressure that physically compresses the capillary beds. Combine that mechanical compression with the pharmacologic vasoconstriction of the extremely dilute epinephrine in the solution, and blood loss drops to less than 1% of the total aspirate.
Less than 1%. That's incredible. But tumescent isn't the only modern standard. We also have the super wet technique, which uses a 1-to-1 ratio, 1 milliliter of infiltrate for every 1 milliliter of planned aspirate. It achieves roughly the same negligible blood loss. But mechanically, why would a surgeon choose super wet over tumescent?
It comes down to volume management. Super wet is favored when treating very large areas. By dropping the ratio from 3-to-1 down to 1-to-1, you significantly decrease the total systemic fluid load placed on the patient's cardiovascular system,
Which drastically lowers the surgical risk of third spacing and subsequent pulmonary edema.
Exactly.
Let's look at the pharmacology of these wetting solutions. The two classic recipes are Klein's solution and Hunstadt's solution.
Yes.
Klein uses 1,000 mils of normal saline mixed with 500 to 1,000 milligrams of lidocaine, 0.65 milligrams of epinephrine, and 10 milliequivalents per liter of sodium bicarbonate to buffer the acidity and reduce burning.
Whereas Hunstadt's relies on Ringer's lactate, with 500 milligrams of lidocaine and 1 milligram of epinephrine.
And because we are using such massively dilute concentrations for infiltration, it radically alters the safety profile of the lidocaine.
It does. In traditional local anesthesia, your maximum safe dose of lidocaine with epinephrine is 7 milligrams per kilogram.
Right.
But with this highly dilute tumescent infiltration, the ceiling is shattered. You can safely administer up to 35 milligrams per kilogram of body weight, and some protocols push that to 55 milligrams per kilogram in carefully selected patients.
I want to push back on the pharmacokinetics of that because it genuinely confuses junior residents. In any other regional block or local infiltration, lidocaine peaks in the plasma within 10 to 60 minutes.
Sure.
But the boards insist that with tumescent infiltration, the plasma level doesn't peak for 10 to 12 hours. Why does it take half a day to peak?
It's the depot effect. You have to look at the tissue you are injecting. You're pumping this fluid into white adipose tissue, which is relatively avascular compared to muscle.
Okay, that makes sense.
Second, you have induced profound, sustained vasoconstriction with the epinephrine. And third, lidocaine is highly lipophilic. It binds tightly to the fat itself.
So it just sits there.
Exactly. These three factors mean the systemic absorption is incredibly slow.
Which means the onset of catastrophic systemic lidocaine toxicity, seizures, arrhythmias, cardiovascular collapse, can be significantly delayed.
Yes. You must monitor these patients long after they are discharged from the PACU. It's a delayed metabolic time bomb if you miscalculate your doses.
Let's look at the surgical tools. We've evolved from traditional manual suction. We now use energy-assisted devices. It's kind of like switching from a manual handsaw to a suite of power tools.
That's exactly what it is.
Let's break down the physics of these modalities. Let's start with UAL, or ultrasound-assisted liposuction, commonly known as VASER.
UAL uses ultrasonic energy delivered via a solid titanium subcutaneous probe. The rapid vibration generates acoustic cavitation. Yeah, essentially creating microscopic bubbles within the tumescent fluid that rapidly expand and implode. This mechanical implosion selectively emulsifies the adipocytes while sparing the denser fibrous and vascular networks.
So it's incredibly effective for highly fibrous areas like the upper back or treating dense male gynecomastia.
And it significantly reduces operator fatigue.
Then you have Thalial or power-assisted liposuction. There is no thermal energy here, right?
None. It uses an electric or pneumatic motor to provide a rapid, reciprocating back and forth mechanical motion to the cannula.
It simply amplifies the surgeon's physical movements to shear the fat with less exertion.
Right. And then we move to the purely thermal technologies, laser lipolysis and RFAL.
Okay.
Laser lipolysis utilizes small fiber optic probes to deliver specific wavelengths of laser light directly to the subcutaneous tissues. The heat literally melts the fat and causes thermal damage to the dermal collagen, triggering neocollagenesis and enhanced skin contraction.
But the danger there is the risk of full-thickness thermal tissue burns if the operator dwells in one spot too long.
Exactly. You have to keep moving.
And to explain RFAL, or radiofrequency-assisted liposuction, I like to use a kitchen analogy.
Let's hear it.
Traditional electrocautery is like a hot plate. It burns whatever touches the surface. But RFAL is more like a microwave. You have an internal electrode inserted into the fat and an external electrode gliding on the skin.
Right.
The radiofrequency current passes directly through the tissue between them, exciting the molecules and generating highly uniform heat from the inside out.
That's a great way to visualize the energy flow. It coagulates adipose, vascular, and fibrous tissue simultaneously, resulting in profound soft tissue contraction.
But the introduction of these massive fluid shifts and thermal energy devices bridges us directly into the complication profile. Because you aren't just contouring fat, you are fundamentally altering the patient's hemodynamics.
Exactly. Let's trace that causal link. You've just pumped 5 liters of tumescent fluid into the subcutaneous space. While the patient is on the table, that fluid is third-spaced.
But 24 to 48 hours later, that fluid inevitably mobilizes back into the intravascular space.
And if you've mismanaged your IV fluids during the case, their right heart is suddenly overwhelmed,
Leading directly to the catastrophic complication of fluid overload and pulmonary edema.
That is the exact mechanism of delayed pulmonary edema in these patients. Other severe complications you must recognize include massive hypovolemia from under-resuscitation and pulmonary embolism.
And remember that PE can be a standard venous thromboembolism from immobility, or it can be a macroscopic fat embolus forced into the venous circulation by the physical trauma of the cannula.
A critical distinction for the exams.
What about direct surgical emergencies on the table?
Perforation. If you lose track of your cannula tip, especially in a patient with an undiagnosed fascial defect or divarication of the recti, you can easily perforate intra-abdominal or retroperitoneal organs.
If you hear a sudden rush of air or aspirate bowel contents?
You are instantly looking at an emergency laparotomy, and the patient may wake up with a temporary stoma. Other fulminant emergencies include necrotizing fasciitis, requiring massive surgical debridement, and toxic shock syndrome.
And once the physiological dust has settled, the late complications are primarily aesthetic, right?
Mostly, yes.
Persistent contour irregularities that demand revision and permanent hyperpigmentation from hemosiderin deposition where superficial vessels were shredded.
Correct. Safety and aesthetic precision require immense respect for the tissues.
Which perfectly transitions us from destruction to reconstruction. We've spent this entire session talking about how to safely destroy and remove fat. But fat grafting, also known as lipofilling or structural fat grafting, harnesses this tissue for everything from facial rejuvenation to complex breast reconstruction.
It's a remarkable tool.
But when we harvest and inject this fat into a new site, how does it actually survive?
There are 3 core theories of graft survival you will be tested on. The first is the cell survival theory.
Which is pretty straightforward.
Very. This proposes a direct correlation. The success of the graft is entirely dependent on the absolute number of intact surviving adipocytes that you manage to physically transfer.
Then there's the host replacement theory.
This argues the opposite, that the injected fat actually undergoes necrosis and dies, but the cellular debris triggers an inflammatory cascade that recruits the host's own adipocytes to populate the injection site.
But the third theory is where the cutting-edge regenerative science lies. The niche theory.
Yes, the niche theory focuses on the adipose-derived stem cells, the ADSCs, located in the stromal vascular fraction of the fat. This theory dictates that a stem cell's physiology and ultimate fate are entirely regulated by its specific microenvironment, its niche.
So the extracellular matrix, the local cell-to-cell interactions, and the paracrine hormones of the recipient bed, they basically send signals to those grafted ADSCs, telling them what to become. And this brilliant mechanism explains why fat grafting works so miraculously in hostile, irradiated environments. The ADSCs don't just sit there as fat blobs. Depending on the biochemical signals of the niche, those stem cells can differentiate into new bone, muscle, cartilage, and actively form new blood vessels to heal heavily scarred radiotherapy fields.
It is tissue engineering occurring naturally. But to harness that regenerative power, you must keep the cells alive during transfer.
Which brings us to the gold standard protocol, Sidney Coleman's technique. Walk us through the exact pressures and physics of his three phases: harvesting, refinement, and placement.
The overriding goal of Coleman's entire protocol is to minimize mechanical shear stress and trauma to the delicate adipocyte membranes.
Okay, so starting with harvesting.
For harvesting, you infiltrate a 1-to-1 ratio of very dilute local anesthetic. You use a blunt 3 mm harvesting cannula connected to a small 10 ml syringe.
And you absolutely do not use a machine vacuum.
Never. A mechanical wall suction creates intense, rapid pressure gradients that physically shear and lyse the cells. Instead, you manually withdraw the plunger, applying a very gentle, controlled 1 to 2 mils of negative pressure as you glide the cannula.
Okay, you have your syringe of raw, unprocessed aspirate. How do we refine it to isolate the gold?
You seal the syringe with a plug, remove the plunger, and place it in a centrifuge. The board-tested gold standard setting is 3,000 RPM for exactly 3 minutes.
And that centripetal force separates the aspirate into three distinct layers based on density.
Right. The top layer is a yellow oil supernatant. This is the free lipid released from cells you accidentally destroyed. You must decant that and wick it away, as free oil causes massive inflammation.
What's the bottom layer?
The bottom layer is a heavy fluid subnatant consisting of blood, water, and local anesthetic, which you drain away. The middle layer is your pure, highly concentrated, viable fatty tissue.
Are there alternative refinement methods commonly tested?
Yes, though they are less standardized. There's sedimentation, where you simply let the syringe stand vertically for an hour to separate by gravity.
Or filtration, where you wash the fat over sterile mesh?
Right. There's also towel processing, which is rolling the fat on sterile cotton towels to absorb the excess fluids. Or the no-touch technique, where you immediately inject fat harvested from an exsanguinated limb without any processing or exposure to air at all.
Finally, placement. How do we ensure this meticulously refined fat actually survives in its new home?
You transfer that refined fat into tiny 1 ml syringes. You inject using blunt cannulas, laying down microscopic tracts of fat as you withdraw.
And the mechanism behind this is pure diffusion. Because until neovascularization occurs days later, that grafted fat survives solely on plasmatic imbibition-absorbing nutrients directly from the surrounding tissue fluid.
Exactly. Therefore, the absolute key is maximizing the surface contact area between the fat parcels and the recipient vascular bed. For the face, Coleman dictates injecting tiny parcels of less than 0.1 cc of fat for each passage.
If you get lazy and inject a massive aggregate or a large blob of fat,
The cells in the center of that blob are too far from the blood supply to diffuse nutrients. They will undergo central necrosis, which leads directly to hard calcifications, oil cysts, and a highly irregular, lumpy aesthetic result.
and if we connect this meticulous cellular science back to the bigger picture, it leaves you with a fascinating question for the future of your practice.
It really does.
We now know that the adipose-derived stem cells found in the stromal vascular fraction of this fat can differentiate into bone, muscle, cartilage, and extensive vascular networks. Given that incredible innate regenerative capacity, could autologous fat grafting eventually evolve to completely replace the traditional synthetic grafts and the highly complex morbid flap reconstructions we rely on today?
It is a profound shift in surgical philosophy. We aren't just moving volume around anymore. We are fundamentally repopulating and regenerating the architectural foundation of the tissue itself.
That is the exact level of mechanistic understanding you need to take into your board exams. Thank you for joining us for this intensive revision session. If you have a question about the physiology we covered today, or want to request a specific topic for your FRCS prep, drop a comment wherever you are listening. Keep studying, trust your preparation, and we will see you on the next deep dive.